Hello friends, welcome to my new video about the reasoning questions of the blood. So first question is that hemophilia is associated with the frequent bleeding and yet severe iron deficiency anemia is rare in hemophilia. Why? So hemophilia is characterized by bleeding into the soft tissue and muscle and weight-bearing joints. Hematuria and epistaxis are common. Despite the frequent bleeding, severe iron deficiency anemia is uncommon because of the bleeding is internal and its iron is recycled, so that the hemophilia is associated with the frequent bleeding even though severe iron deficiency anemia is rare in hemophilia. The intestinal absorption of the iron is impaired in patients with the gastrectomy. Why? Gastric acid is necessary for the iron absorption as it dissolves the insoluble ferric salts and complexes. The dissolved ferric form complexes with reducing substances in the diet like ascorbic acid and cysteine that is present in meats and is reduced to ferrous form. Hence, the iron absorption is impaired in patients with the gastrectomy or achlorhydria. Local hemosiderosis develops when there is a hemorrhage into the tissues. Why? So macrophages phagocytose the red cells and store their iron as a ferritin and hemosiderin. If the hemorrhage is small, the macrophages migrate away from the site. But if the hemorrhage is large, the hemosiderin-laden macrophage remain at that site. So that local hemosiderosis develops when there is a hemorrhage into the tissues. Plasma proteins prolong the half-life of hormones in the blood. Why? The carrier function of the plasma proteins helps in prolonging the half-life of hormones in the blood. By binding to them, plasma protein prevent the rapid elimination of the hormones through glomerular filtration. And then the protein-bound hormone also acts as reservoir of the hormone. And when the free hormone level falls, the bound hormone readily dissociates from the carrier protein and restores the free hormone level. So in this way, the plasma protein prolongs the half-life of the hormones in the blood. Severe anemia may be associated with the palpitation and cardiac murmurs. Why? In severe anemia and palpitation due to compensatory increase in the cardiac output, the raised cardiac output creates a turbulence of the blood during its passage through the cardiac valves, that resulting in clinical signs like cardiac murmur. The reduction in the red cell count reduces the blood viscosity and thereby contributes to the turbulence and then resultant murmurs. About 10% of the glycolysis in the erythrocyte occurs through the pentose phosphate pathway. What is its significance? The 10% of the glycolysis occurs through the pentose phosphate pathway, also known as hexose monophosphate or HMP shunt. The significance of this pathway is that it generates NADPH H+, which is required for the reduction of glutathione. The reduced glutathione protects the sulfhydryl group of hemoglobin against oxidation. So NADPH is also needed in some way for the maintenance of the normal red cell fragility. The Embeden-Meyerhof pathway is slightly different in the erythrocytes as compared to other cells of the body. Then what is the physiological significance of this difference? 90% of the glycolysis occurs through Embeden-Meyerhof pathway, but with a difference. So first of all, in erythrocytes, the glycolytic step catalyzed by the phosphoglycerate kinase is bypassed. The significance of this modified pathway is the production of 2,3-diphosphoglycerate that influences the oxygen affinity of the hemoglobin and thereby has important physiologic consequences. Acidemia that decreases the 2,3-diphosphoglycerate in the red blood cells by hindering glycolysis, and hypoxia that increases the 2,3-diphosphoglycerate by inhibiting the Krebs cycle. Another advantage of the Embeden-Mayer pathway is that it generates NADH plus H plus. Normally, the methemoglobin is formed continually by the autooxidation of hemoglobin. Simultaneous reduction of the methemoglobin by NADH plus H plus keeps the methemoglobin level low, below 1% of the hemoglobin content. The production of erythrocytes increases whenever there is a increased destruction of erythrocytes. How? The stimulation of the erythropoietin by hypoxia is a feedback mechanism through which the number of the erythrocytes produced increases whenever there is an increased destruction of the red blood cells resulting in the release of hemolysates and causing hypoxia in the tissue. So the increase in the red blood cell count tends to improve tissue oxygenation. In iron deficiency, plasma transferrin increases. Why? The plasma protein that transports the iron is called transferrin. Transferrin is synthesized chiefly in the liver. Its rate of the synthesis is inversely related to the amount of the iron stored in the body. So, in the iron deficiency, the plasma transferrin increases. In congenital transferinemia, the tissues are loaded with the iron, but the erythrocytes show the signs of iron deficiency. Why? Now, clinically, the amount of the transferrin is expressed in the terms of the amount of the iron it will bind. That is the total iron binding capacity. Transferrin mediated transport ensures the delivery of the iron only to those cells that need the iron, and that is the red blood cell precursors. Unbound iron becomes distributed to all the cells equally irrespective of their iron requirement. The importance of the transferrin is apparent in congenital atransferinemia, where erythrocytes show the sign of iron deficiency, but the tissues are loaded with the iron. Hemolytic hemosiderosis is seen in hemolytic anemia, and it is also known as transfusional hemosiderosis because it occurs following repeated blood transfusion. Initially, the hemosiderin accumulates in the mononuclear phagocyte system cells. But in prolonged and severe cases, the parenchymal cells, like those of the liver and myocardium, that are overloaded with hemosiderin. Siderocytes appear in the blood in significant numbers only after splenectomy. Why? When the non-heme iron is present in the red blood cells in excess of what is required, it clumps into the granules called siderotic granules. Erythrocytes containing such granules are known as siderocytes. Normoblasts and reticulocytes containing siderotic granules are known as sideroblasts. Sideroblasts released from the bone marrow are trapped in the spleen, where they remain till they complete the heme synthesis and using up their excess iron stores. Hence, the siderocytes appear in the blood only after splenectomy. In folate deficiency, there is a marked rise in the urinary excretion of the 4-aminoglutamate, FIGLU. Why? 4-amino, 4-aminoglutamate, FIGLU, which is an intermediate product of histidine metabolism and transfers its 4-amino group to THF, tetrahydrofolate, to form 4-amino THF. In folate deficiency, there is a marked rise in the urinary excretion of FIGLU after a large dose of histidine. The test is, however, not specific for the folates. It is positive in vitamin B12 deficiency too. And this is because in the absence of the vitamin B12, a lot of tetrahydrofolate remains trapped in the methyl trap, causing deficiency of tetrahydrofolate in the body. Although vitamin B12 is synthesized only by bacteria and fungi, humans derive their cobalamin entirely from the animal sources. How? The vitamin is synthesized only by the bacteria and fungi. It is absent from the plants unless they are contaminated by the bacteria or fungi. Although colonic bacteria synthesize cobalamin, the colonic cobalamin are unabsorbable in the human, and animals, especially ruminants, are however able to absorb colonic cobalamins. Humans derive their cobalamins from the milk, meat, and especially the liver of these animals. The commercial preparation is cyanocobalamin. Patients of the von Willebrand disease, a bleeding disorders, are administered disamino-arginine vasopressin just before the surgery. Why? In von Willebrand disease, patients bleed excessively due to congenital deficiency of von Willebrand factor, and its incidence is about 1 in 1000, and if one considers subclinical cases too, it is as high as 1 in 100. In addition to promoting the platelet adherence, von Willebrand factor serves as a carrier protein for the factor 8 in the plasma and increases its plasma half-life. In the absence of the von Willebrand factor, factor 8 cannot be maintained at adequate level in the plasma, and analog of the vasopressin, disamino-arginine vasopressin, is often given to these patients just before the surgery to induce endothelial cells to release their stores of von Willebrand factor, so that in the patients of the von Willebrand disease, the disamino-arginine vasopressin are administered just before the surgery. The absorption of the vitamin B12 is impaired in achlorhydria. Why? The dietary vitamin B12 is bound to proteins. In the acidic pH of the stomach, vitamin B12 dissociates from the dietary protein and binds to heptocorrin, also called R binder, that is present in swallowed saliva. The absorption of the vitamin B12 is impaired in achlorhydria because it is not released from the dietary proteins, and it is also impaired in pancreatic insufficiency because it is not released from the R binder, so that absorption of the vitamin B12 is impaired in achlorhydria. Vitamin B12 deficiency is associated with methylmalonic aciduria. Why? Inside the cells, the cobalamin is converted into its active form, methylcobalamin and deoxydenosylcobalamin. Deoxydenosylcobalamin is a coenzyme for an important step in gluconeogenesis. Deoxydenosylcobalamin is the enzyme for the conversion of methylmalonine CoA to succinyl CoA. The urinary excretion of methylmalonyl coenzyme A is increased in vitamin B12 deficiency. Methylmalonic aciduria has been used as a test for vitamin B12 deficiency. So that vitamin B12 deficiency is associated with the methylmalonic aciduria. Disseminated intravascular coagulation, usually occurs in metastatic malignancies and gram-negative septicemia, and it is also commoner during the pregnancy. Why? So DIC usually occurs in metastatic malignancies and massive trauma because malignant or necrotic tissue that release tissue factor into the circulation that triggers the coagulation. Disseminated intravascular coagulation that also occurs in gram-negative septicemia because the endotoxin from the gram-negative bacteria activates factor 12 and stimulates the secretion of the tissue factor. And disseminated intravascular coagulation is also common during the pregnancy because it is associated with the rise in the plasma fibrinogen and von Willebrand factor. Disseminated intravascular coagulation also occurs following snake bite. The venom of the Malaysian pit viper has a direct effect on the fibrinogen in converting it to fibrin, so that disseminated intravascular coagulation that occurs following the snake bite. Dicumarol and warfarin are effective anticoagulants, and yet they are not preferred during the dialysis of the blood. Why? Coumarin derivatives such as dicumarol and warfarin are effective anticoagulants that can be used in vivo. This compound inhibits the reduction of the vitamin K to its active form vitamin Kh2, resulting in impaired synthesis of the factor 2, 7, 9 and 10. The anticoagulant effect of the coumarin derivative cannot be reversed quickly and therefore cannot be used in dialysis. Inadequate dietary intake of the vitamin K usually does not cause vitamin K deficiency. Why? So vitamin K is obtained in part from the food, especially green leafy vegetables, and as vitamin K1 or phenyloquinone, and partly from the intestinal bacterial flora, which synthesize the vitamin as menaquinone. When one source is deficient, the other compensates. Dietary vitamin K1 is a fat soluble and requires bile salts for its absorption. Menaquinone is a water soluble and is absorbed even in the absence of the bile. So in the liver, vitamin K is reduced to vitamin Kh2 or reduced hydroquinone, which is physiologically active form. So liver cells store enough vitamin K to last a month, and therefore inadequate dietary intake is not common cause of vitamin K disorders. Aspirin inhibits the synthesis of both thromboxane and prostaglandins. Yet aspirin causes a reduction in the platelet activation. Why? Now normally a delicate balance exists between the thromboxane A2, which promotes the platelet aggregation, and prostacyclin, which inhibits the platelet aggregation. Both are produced by cyclooxygenase pathway of arachidonic acid oxidation. Also, the synthesis of both are inhibited by aspirin, which irreversibly inhibit the cyclooxygenase pathway, both in platelets and endothelial cells. However, the nucleated endothelial cells resume prostacyclin synthesis much earlier than the nucleate platelets. which are able to resume the thromboxane synthesis only after the new platelets are formed from the megakaryocytes. Hence, the aspirin that reduces the platelet activation and aggregation, making it a valuable drug for the prevention of thrombosis. Nylon, polyacrylamide and Teflon are not immunogens. Why? An antigen is usually a high molecular weight protein, but it may also be a low molecular weight protein, for example insulin, or a high molecular weight polysaccharides like dextran. Immunogenic molecules require some degree of chemical complexity. Large substances lacking chemical complexity such as nylon, polyacrylamide and Teflon are not immunogens. The fetus is genetically different from the mother, and yet it does not evoke an immune response in the mother. Why? First of all, the placenta is resistant to immune attack because after implantation, the trophoblast lose much of their immunogenicity due to decrease in the density of the major histocompatibility complex antigens or the development of an inert coating of the mucoprotein on the surface of these cells. Second is maternal antibodies are absorbed by the placenta, preventing their entry into the fetal circulation. Then third reason is that the alpha fetoprotein and progesterone produced during the embryonic development are immunosuppressant so that the fetus is genetically different from the mother and it does not evoke a immune response in the mother. Thank you very much, and if there is any question regarding this lecture, please write down in comment section and please give me a feedback. Again, thank you for your attention.